Okay, sir, let me start. An exhilarating welcome to all the delegates over here. Myself, Raghunandan Ramanathan, on behalf of Medusane, here introducing Dr. Balaji, sir, who is going to discuss a clinical case, newborn case for the pediatrics. So I welcome you, sir. I also welcome Balaji. I also welcome Shridin Kumar, my senior, as well as my friend, who is here to present the case on newborn. So Dr. Balaji, sir, is Professor of Pediatrics from SRM Medical College. He is awarded 3 gold medals while studying post-graduation, over 10 years of teaching experience. He has attended medical education training by Partners Medical International in USA. He is very passionate in teaching students. He is a constant support for Medusane too in providing us Zoom paid version, and also he extends his support in all his lectures. So I welcome you, sir. He is also having a Telegram channel, Medusane, where he used to discuss MCQs and clinical cases. I request everyone even to join that channel and get educated by him. Thank you, sir. And now I hand over the session to Dr. Balaji, sir.
Thank you, Raghav. Thank you. You're doing a wonderful job at this lockdown period when classes are not going on. You're doing a wonderful job by connecting teachers to students. I hope students are benefiting a lot by your efforts. Keep continuing your good efforts. And today, I also welcome our student, Shridin. Good evening, Pa.
Good evening, sir.
So today we will be discussing about newborn. So Shridin, it's up to you. You can start presenting your case. And before that, just an overview. Newborn, it's actually a bigger topic, but what I will be discussing is the important questions which will help you passing out on the exam. Because for the past 10 years, I have been teaching students more than excelling. I'm more concerned about you should get through the exams. So the most of the questions are the basic questions which will help you, how the examiner's mind frame is, what are the important questions they will ask you, which will fetch you to cross that line. Okay. The most important will be the flow. You should present it like a story without much of confusion. As long as you do till the end, you do the discussion. Each and every part, the teacher might ask you questions relevant to that. If you answer those questions, I think you will be through to your exam. So management part or investigation part, they will not go much. Before that itself, you are pass. Okay. So Shridin, keep presenting.
Yes, sir. Thank you, sir. So my case is Mrs. Rani, who is a 25-year-old primary from Perungalattur, came to Tagore Specialty Hospital, Chennai. To start with, baby of Mrs. Rani, a 39-week gestational age baby boy, now 5 days old, born to a 25-year-old primary mother of non-consanguineous marriage. The parents are hailing from Perungalattur. The baby was born on 22nd of July 2020 at 6 p.m. by normal vaginal delivery at Tagore Specialty Hospital. The mother's LMP was on 21st of October 2019 and the expected date of delivery was on 29 July 2020. Mrs. Rani, who is the informant of the baby, is her mother and her reliability is good, who is belonging to a family of lower middle class, that is class 3 according to the modified Kupasamy scale. Presently, the baby is in the mother's room for routine newborn care.
Okay, Shridin. So the first slide is related to the demographic details. So you need to understand the components, what we are going, the order is important. So the first will be the demographic details. And what I suggest is try to keep it as crisp as possible, keep it uncluttered, and there is no right or wrong. What Shridin is done is also good, and what I'm going to do is also correct. It's just the way of presentation. And another thing is each examiner expects some style. So don't worry about, and you have to know what your internal examiner has taught, and accordingly we have to modify. So there is no this is right, this is wrong. So there is a style of presentation. That's all. Okay. So I like to keep it as simple as possible. So a 5-day-old baby, Mrs. Rani, baby of Mrs. Rani, born as a non-normal vaginal delivery, 1 week before due date on 22nd July 6 p.m. So 1 week before due date explains you what was the due date and when was the child born. So no one is worried about exactly what is the expected date of delivery. What we are bothered is how many days before the baby was born. Okay, so 1 week before due date on 22nd July 6 p.m. Informant being mother who stays at Perungaluttur. And I think it's a known fact that reliability should be good if it's mother. So we should try to keep it less cluttered. And what for the baby has come. So it could be without any complaints. The baby is staying in the hospital because of the maternal reason, or mother could have brought the baby for yellowish discoloration or inadequate breastfeeding, or the baby is a premature baby staying in the hospital because of preterm care. So any one complaint, the mother will be coming, either no complaint or jaundice or inadequate breastfeeding or premature baby for preterm care. So if there is any complaint, you have to go to the elaboration of the complaints. Okay, if there is no complaint, then you can straight away go to the antenatal history. Okay, so if there is suppose there is a complaint, Shirin, I will just elaborate this. Suppose the baby comes with a jaundice. So you have to elaborate the jaundice to get some information. So whether it is physiological or pathological jaundice, we all know that day one jaundice is going to be pathological jaundice. So what day of the jaundice appeared? Similarly, what is the severity of jaundice? So these questions you have to ask the mother. So regarding the distribution of the yellowishness, suppose the palms and soles are yellow, the mother says palms and soles are yellow, then the jaundice is a bit severe. Mother often says the eyes are yellow, which is not so severe. Mother often comes with eyes are yellow, they are worried, but actually the almost all babies physiologically have some yellowish discoloration till 1 month of age. Similarly, we need to understand what is the cause for jaundice. You can ask questions like what is the mother's blood group, what is the baby's blood group. So Rh negative mother, Rh positive baby, Rh incompatibility is there. Similarly, mother O positive, O blood group, and baby A or B blood group, that also can cause jaundice. Cephalometoma. Suppose mother says that there is a swelling in the head after birth, so it could be cephalometoma or feeding related issues. So breastfeeding, decreased breastfeeding resulting in increased enterohepatic circulation, and jaundice keeps piling up. So decreased breastfeeding resulting in breastfeeding jaundice. Okay, so you have to ask questions related to the severity, related to the etiology. Similarly, whether it is direct or indirect hyperbilirubinemia. So you can ask questions like how is the stools? Is it yellow or is it chalky clay colored stools? Okay, so direct or indirect hyperbilirubinemia. So first will be demographic details. Keep it as simple as possible. Demographic details, keep it as simple as possible. Okay, and then go to complaints. If there is any complaints, try to elaborate the complaint. Try to get some meaningful data as I elaborated it. Okay, then suppose there is no complaints, then go to the antenatal history. Okay, Shirin, you can continue more.
So now the antenatal history. First trimester, folic acid was taken regularly. Ultrasound dating scan was done along with other serological blood tests, and urine routine was done, and it was normal. There was no history of excessive vomiting. There's no history of fever with rash or lymphadenopathy or any intake of drug or any history of hospitalization. There is no history of exposure to radiation, and there is no history of bleeding or spotting TB.
Okay. Okay, Shirin, what you are concerned in first trimester?
Uh, Sir, I have
what are the questions?
So during the first trimester is the period of organogenesis. So I want to check to it that what are the things which may affect the organogenesis period from the mother side, sir.
Okay, that's good. That's good. So the first trimester, very important is I'm bothered about whether the case is a booked case or not. So whether the mother is registered for regular care. Okay, regular visits to the hospital so that the mother and baby are fine. So we need to be sure whether the mother is booked or not. And as he said, first trimester is the period of organogenesis. So be sure about teratogenicity. Okay. So torch infections. So you have to ask questions related to torch infection. So fever, rash, and swelling in the neck and occiput region. So fever, rash, and the occipital lymphadenopathy. So that's related to torch. Drugs. Any drug is a potential teratogen. So you have to take history of drugs. And they will ask you questions what drugs can cause what teratogenicity. Okay, so lithium, Epstein's anomaly, Hydantoin, fetal Hydantoin syndrome. Okay, so phenytoin, fetal Hydantoin syndrome. Valproate, you can get cleft and the neural tube defect. So you need to be aware what are the drugs which will cause the teratogenicity. Similarly, radiation, any accidental exposure to radiation. Okay, and folic acid supplementation. Okay, so we need to be, and folic acid is given even before conception. Okay, so it's a 400 microgram. And suppose there is a family history of any neural tube defects, early sibling, then it has to be 4 milligrams, 4 to 5 milligrams. Okay, and make sure that each trimester has one scan. So you should know that. So dating scan for knowing the exact gestational age. So dating scan. And in the late first trimester, we do the nuchal translucency scan to screen for congenital abnormalities. So that is for the first trimester. Similarly, for second trimester, you have one more scan, which we will go through it. So first trimester, make sure that you have asked questions related to teratogenicity. Make sure whether the mother is a booked or not, and whether that important scan, dating scan, but nuchal translucency scan, and folic acid supplementation has been given. So they might ask you questions related to what is the dosage, etc. Okay. Next, ma.
Second trimester, quickening was felt at 5th month. Both iron and calcium tablets were taken regularly, along with folic acid was continued. Immunized with TT vaccine at 4th and 6th months, respectively. Anomaly and NT scan was taken and showed normal study. There is no history of headache, blurring of vision, epigastric pain, or pedal edema. There is no history of bleeding PV, and there is no history suggestive of gestational diabetes mellitus. So,
Okay, so Shidan, what you are basically concentrating in the second trimester?
so the events which complicates the pregnancies are like in case of diabetes and hypertension, PI,
Okay, good. And plus the supplementation. Okay, so initially it was folic acid. So now in the second trimester, you start adding the iron and calcium. Okay, and make sure that the vaccination has been given, tetanus toxoid has been given. And one more important scan which you are going to do will be the anomaly scan. So at around 20 weeks, we do the scan, that is the anomaly scan. And we are concerned about iron and folic acid supplementation and TT vaccine. And there are specific pregnancy related maternal illnesses, okay, like gestational diabetes mellitus, pregnancy induced hypertension, which comes up in the second trimester. So that you can ask at this point of time. Similarly, quickening, what does quickening imply? It comes around, they might ask you when it comes around 20 weeks or 5th month. What do you mean if quickening is felt less frequently? What do you understand, Shidan? Suppose the quickening is felt
in
less
case of
frequently.
delayed quickening, there may be any congenital myopathy, or in case of spinomuscular atrophy, or any fetal distress for that matter, sir.
Okay,
So which can
so
delay the
any
quickening.
fetal, okay, so it means that the baby is not fine. So either the baby is having some hypoxia and distress, so that's why the frequency is coming down, especially during the third trimester when the quickening starts coming down. So even actually mother has to count the fetal kick count, no fetal counts kicks. She starts counting. Okay, so decrease the frequency means some compromise is happening. Similarly, if the baby's muscular tone is less, as in SMAs, etc., so the frequency might be less. But at the same time, sometimes babies can even get seizures. Okay, fetal intrauterine, they can get seizures where the quickening might be felt suddenly. A burst of increased frequency can be there. So these all you can get in the screening. Okay. Then next.
Third trimester, history of normal fetus movement felt. All the 3 medications were taken regularly. Growth scan was done, and there's no history of fever or convulsions. There's no history of suggestive of PIH or JDM. There is no history of bleeding or foul-smelling discharge per vaginum was found. There is no history of dysuria, burning menstruation, or any other symptoms of urinary tract infection.
Okay, perfect. So in the third trimester, what do you think are the concentrations?
So in this, we must ask whether the risk factors for sepsis, as in like any event which complicates the delivery during the delivery.
Okay, okay. So third trimester is basically is very close to the delivery. So any event might affect the baby after delivery. So most important will be the infection. Okay. So we are screening for any issues that might affect the baby immediately after birth or early sepsis. Any features that can affect causing early sepsis. Okay. It could be burning menstruation and UTI. So UTI can affect the baby causing early sepsis, or it could be a foul smelling liquor, which means that there is some infection, or mother having fever and lower abdominal pain, okay, or the medical complications which we said. How has it been? Has it increased? How is the PAH and GDM? Has the PAH progressed to eclampsia and seizures? Has the GDM has become uncontrolled, or the GDM is now controlled? Similarly, as we said, for each trimester there is one scan. So first will be your dating scan, next will be your anomaly scan, and in the third trimester you look for the growth scan, how the baby is growing. You look for the amniotic fluid index, so whether the fluid is liquor is adequate or not, is the baby growing well or not. Okay, so how is the baby basically? Okay, so they do the biophysical profile and start prognosticating how the baby is the baby fine or not. So growth scan is very important. Okay, so next.
Perinatal history, spontaneous onset of labor at term. Onset of labor pain started on 22nd of 7/20 at 8 a.m. Rupture of membrane at 12 p.m. on 22nd of July 20. Labor augmentation was done with oxytocin. The duration of labor was 18 hours. Full-term live baby boy was delivered in vertex presentation by normal vaginal delivery at 6 p.m. on 22nd of July 2020 in the labor ward of Tagore Specialty Hospital.
Okay, so what do you feel that you have extracted from the perinatal history?
From this, we can know whether the labor was spontaneous or insidious onset, and
Okay,
whether they needed augmentation of labor with oxytocin, and
okay,
the entire duration of labor, that is around 18 hours. So, in case of prolonged labor, we can indicate as in whether the baby would be undergoing prolonged period of asphyxia or some sort of
okay. So now how do
distress.
you feel that 18 hours looks a bit prolonged or not?
uh, Towards the borderline, I suppose.
Okay, so around 18, anything beyond 18 to 20 hours, we take it as prolonged labor. Okay, and as you say, this might affect the baby's oxygenation. Okay, it can cause intrauterine hypoxia when the labor is keeping on prolonged. Okay, so we in the perinatal history, what we are going to see is, has everything gone fine? How is the entire process of labor? Was there any difficulty? Okay, is the labor prolonged? So prolonged, not only hypoxia, there is one more risk is the membranes might have ruptured early. So infection can also occur. So when there is a prolonged labor, premature rupture of membranes, repeated pervaginal examination will be done to know whether the baby is fine or not. Physician will be doing repeated PVs. So these are all risk factors for sepsis also. So sepsis risk factor, as well as since the baby is inside and labor is prolonged, the uterine is contracting, so the intrauterine hypoxia is also possible. And you're going to further ask whether any assistance you used to deliver, whether it didn't happen normally. Did you use any forceps? Did you use any vacuum? And if the labor failed induction, did you go for LSCS? Okay. If cesarean you have opted, what was the indication for the cesarean? Was it like arrest of the labor, or really the baby was at distress, so fetal distress? What was the indication for the cesarean? So these are all the questions the examiner expects from you during the perinatal history. And finally, after, how is the baby? So the boy baby was born. and at what time the baby was delivered, so that you are elaborating. But mainly they will be concentrating on what happened during the labor period. Exactly. Okay. Was there any difficulty in delivering the baby? Did you use anything? Okay. And did the labor was a prolonged, making the baby at risk for hypoxia as well as for sepsis? Okay. Then
Postnatal history. The baby cried at birth. His birth weight was 3.1 kgs. Handed over to the mother soon after birth, breastfed soon after birth. No prelactal feeds were given, and there's no history of any complications. The baby passed urine and meconium within first 24 hours of life. There is no history of any feeding problem and was fed on demand approximately 2 hourly. There's no history suggestive of jaundice, convulsions, or any respiratory distress, or any history of neonatal admission.
okay. So what do you think you elicit in the postnatal history?
So, if the baby didn't cry immediately at birth, whether there was any resuscitation procedures done, and
Okay.
the breastfeeding, when was it, based on that, whether the breastfeeding was started or any uh, like any delay due to any reason,
Okay. Good.
and
Good. Then after that, whether the baby passed the urine and meconium within 24 hours or not. And postnatal doesn't stop. Actually, postnatal has two parts: the immediate part and the later on part till you see. Till you see have seen the baby. Okay. So the immediate part will be the resuscitation part. Okay. So did the baby cried immediately or not? So what does immediately cry mean, student? Immediately cried after birth means what?
so not sure, sir.
So immediately cried means the respiration has initiated. So the first cry is nothing but the baby is crying out of pain. It is the first respiration. So immediately cried means the baby immediately started breathing. Okay. So immediately cried after birth, or was there any delay in the cry? If there was any delay in the cry, the pediatrician, what type of resuscitation assistance did the pediatrician do? So did the pediatrician do only the stimulation and the initial steps of resuscitation, or did he use any bag and mask to give positive pressure ventilation, or did he have to intubate till then? So the resuscitation by the pediatrician, maybe the parents may not know everything in detail. At least the pediatrician would have updated the uh, mother regarding the difficulty in delivering. Okay, the difficulty in resuscitation. Okay. Uh, able to hear? Hello, student.
Yes, sir. Yes, sir.
I'm hearing some echo. Okay. So postnatal history is about immediately cried after birth, any resuscitation efforts made by the pediatrician. Here you will be asked about Apgar score. Shirin, you have any idea about elaborating Apgar?
So we just grade based on the appearance of the baby, the heart rate, the grimace or the tone, the activity, and the that's the respiration and the reflex. Based on that, we score 0, 1, 2, sir.
Okay, okay. So how much Apgar and above is satisfactory?
So 7 to 10.
Okay, so anything above 7 is acceptable. And so they will ask you about the resuscitation protocol. They expect you to say about the NRP protocol, the flow chart, the initial steps they might ask you. Then how do you know that the baby was sick or not at that time? So any specific questions you will ask to know whether the baby is sick or not.
So not
So
sure, sir.
basically, if the baby is sick, the baby will be admitted in the NICU. Okay. So whether the baby was admitted in NICU, how long was the baby was admitted in NICU? So if the baby was admitted for 1 week, and then you have to elaborate what happened in NICU, whether the baby was kept in ventilator or not. So these things you have to ask. So if everything went well, no problem. The baby cried immediately, and the baby started breastfeeding within half an hour. So that is fine. But if any issues is there, what type of resuscitation efforts were done? what was the, so Abgar, the parents may not be able to ask, but examiner will ask you what is Abgar and what is the acceptable. Similarly, they will ask you the NRP protocol. So you need to know the resuscitation algorithm. So the 3 questions you will be asking. So what do you know the 3 questions which you will be asking? So whether the baby is a term, how is the tone, and did the baby cry or not? So any one question, if it is wrong, you will give the initial steps of resuscitation. Then after 30 seconds, if still the baby doesn't cry, you will start giving positive pressure ventilation. So, and the heart rate is less than 100, you start giving positive pressure ventilation. So you look into the NRP protocol, they will ask you, and you need to know whether the baby was sick or not. If the baby was sick, the baby would have been kept in the NICU. Then you have to ask further questions. What happened in NICU? How long was the baby? Did they give ventilator? Did they give oxygen? Did they give feeding? How was the feeding given? Okay. But if everything is fine, you straight away go to the breastfeeding. How was the breastfeeding initiated? Whether colostrum was given, whether any pre-lacteals were given, and afterwards also you have to check whether there was any feeding problems. So here they will ask you questions related to what is proper attachment and what are proper positioning. Okay, for proper, do you have any idea, Shirin, what is proper attachment?
So the baby's mouth must be widely open, covering the entire areola except the upper part. The baby's lower jaw must be averted. And,
Okay, so they will be asking you those things. So most of the mothers will be just feeding the nipple alone. So the nipple and areola, both the baby should be feeding. So they will ask you the questions related to what is proper attachment. Okay, and make sure the baby has passed urine and meconium within 24 hours of life. Okay, what do you mean if baby didn't pass meconium within 24 hours? What do you suspect, Shirin?
so if the baby doesn't pass within first 24 hours, there may be any bilateral renal agenesis, or we can think on
Anal
about the
agent,
Potter
meconium.
sequence.
Okay. Okay, so meconium didn't pass within 24 hours means major intestinal anomaly might be there. So we have to look for it. Okay. Okay.
Immunization history: BCG, polio, OPV, hepatitis B was given within 24 hours of birth.
Shirin? Able to hear, Shirin?
Yes, sir. Yes, sir. Now it's audible, sir.
Yes, sir, you're audible.
Audible only, sir.
Able to hear?
Yes, sir.
Yes,
Yes,
sir.
sir.
Issues. Okay. Immunization history. So you will be giving BCG, polio, hepatitis B within 24 hours of birth. Okay. And plus, what else you will be asking, Shiran? So you will be asking about socioeconomic history, which you have elaborated earlier. Actually, you can elaborate separately here. So what is the modified Kupuswamy scale? You said it was what was the scale?
Class 3, sir. Low middle class.
So basically, we need to understand how educated are the couple in taking care of the baby. Okay, and family history. So family history and maternal history, we can take a separate history here to know whether it was a consanguineous marriage and married since how many years of now how many years actually married.
So marriage in past 1 year, sir.
and this is the first child, no? So
Yes, sir.
it has been for a long period. They tried any infertility treatment. So this all you can put it in the family history and maternal history. What is the mother's age? Sometimes a delay in the maternal age can lead to chromosomal abnormalities. And how are the
She's
other?
20,
So here it
she's
is the
23 years old.
so first sibling, no, G1.
Yes, sir.
How are the other siblings? How are they? Any miscarriages? So this all you can put it in the family and maternal history. Family history bar maternal history. And in family history, any diseases in the family that runs in the family, it's good. Suppose the baby is having jaundice. So is there any family history of similar jaundice and blood transfusions and gallstones to rule out hemolytic anemias? Similarly, contact history with tuberculosis. Mother is active tuberculosis. So baby can get congenital tuberculosis. So these all you have to elaborate in the family history and maternal history. Okay. Okay. So summary, can you read this summary, Shigan?
Yes, sir. Full-term boy, boy baby of birth weight 3.1 kg, born vaginally with no significant antenatal, perinatal issues, cried immediately, started breastfeeding within half an hour of life, passed urine and stools within 24 hours, immunized, and currently baby is staying in hospital because of maternal reasons.
Okay. So this is the final summary. So summary is basically the positive findings which you have elaborated apart from the demographic data. So demographic data, we said, no, boy, baby, birth weight 3.1 kg, born vaginally. Then antenatally, you had any issues? No. So no significant antenatal history. Perinatal issues? No significant perinatal issues. Then postnatally, the baby cried immediately. Then the baby was not kept in NICU. So negative history, you leave it. So what are the positive history? You tell. Started breastfeeding within half an hour, passed urine and stools within 24 hours, and the baby was immunized. And now the baby is staying in the hospital because of the maternal reasons. Okay. So Shivan, so right from the start, can you see what all components we took care of? So one is demographic data.
Then we checked about the antenatal history.
Okay, suppose there is a presenting complaint, you are going to elaborate the presenting complaint, followed by the antenatal history. In that, one by one, the first trimester.
First trimester, we must ask whether she had any
We concentrated on
lumps
the
and irritation.
teratogenicity, no, organogenesis. Then second trimester, we concentrated on
Maternal illnesses like diabetes,
maternal
mellitus.
illnesses. And third trimester, any risk for the sepsis. Okay. Then perinatal history, we look for any difficulty in labor. What is the process of labor? Then postnatal, how was the resuscitation? Any NICU stay? And how was the breastfeeding? Any breastfeeding issues were there or not? And finally, we make a summary of it. Okay.
Yes, sir.
So
Examination. Term newborn baby boy sleeping comfortably in universal flexion posture. The baby appears pink and normothermic. There is no pallor, icterus cyanosis. The pulse is about 124 beats per minute, regular and normal volume pulse. Respiration is 40 per minute and temperature 37 degrees Celsius and capillary refill time is less than 3 seconds.
okay. So in examination, so first will be the general examination. So most important will be, is the baby awake? We say, no, conscious and alert, conscious oriented. We start with conscious oriented, no? So like that, is the baby awake or asleep? Most often the babies will be asleep. So 16 to 18 hours, they will be asleep. Then what is the attitude of the baby? So the baby is in universal flexion posture means it's a good posture. It's a sign of a healthy baby. So universal flexion posture and the baby is asleep or awake. Okay. And usually the time for examination will be half an hour or 1 hour after feeding. After feeding, when the baby is quiet and comfortable, you do the examination. Then the regular icterus, pallor, cyanosis and edema we look for. So most important, they might ask you now questions is, where will you look for the jaundice? Shidan, where will you look for the jaundice and how do you look for the jaundice?
Sir, we for jaundice we must first we must be in a well illuminated place, preferably sunlight,
Okay.
and we apply gentle pressure via thumb over the prominences. That is, we can press over the sternum, or if there is over the forehead or the thighs, legs, or soles, we must you give a gentle thumb pressure. We must check for blanching, sir.
Okay, so the yellow, we should not look into the eyes. Very commonly, students say, where will you look for icterus? In adults, we look for icterus in the eyes, no, in the sclera. So it's not so. In babies, you have to look into the body, and the order of progression is cephalocaudal. So the more the jaundice, where will you look for the severe jaundice?
Palms and soles, sir.
Palms and soles. If the palms and soles are yellow, so it means the jaundice is severe. Okay, and you look for pallor and cyanosis. What do you understand by the word acrocyanosis, Siddhan?
Sir, in case of acrocyanosis, the lower limb may be cyanosed, or the facial and the upper limb may be like pink.
The peripheries are cyanosed. Does it mean that it is congenital heart disease, cyanotic heart disease? No. So it's basically because of the temperature, environment. So if the environment is a bit cold, the peripheries may be a bit cyanosed. So acrocyanosis, very commonly they might ask you. Okay. And in vitals, we need to know the normal vitals range. Okay, what is the normal heart rate and pulse rate? What is the normal heart rate and respiratory rate? It will be the double R pulse rate and heart rate. So remember that. So suppose our heart rate is around 70, so the babies will be having around 120 to 140. Ours respiration is 20, so baby's respiration will be around 40, around 40. And then temperature, they will ask you very important questions. How will be the blood pressure, Sweden? What will be the blood pressure of babies?
So the blood pressure would be half of that of the adults. So that is
blood pressure. So 120/80. So their blood pressure will be 60/40,
sir.
So, and we cannot measure by the regular manometer cuff. We have to either use automated BP cuff, okay, NIBP, non-invasive blood pressure monitoring. We have to do that, okay. And temperature, very important questions they will be asking you. Temperature, how will you say what is hypothermia, Shridan? What is the definition?
Hypothermia is the body temperature of less than 36.5 degrees Celsius.
Okay, so what is cold stress? I'll ask you about
the temperature like from 36 to 36.4 degrees Celsius.
It's called cold stress. Okay, so how will you ask parents whether the baby is in cold stress or not? So you have to ask whether the peripheries are cold or not. So if the body is warm and peripheries are cold, it means that the baby is in cold stress. If you leave like that, the baby is going to go into full-blown hypothermia. So you have to cover up the baby properly. Okay, and severe hypothermia less than 32 degrees Celsius is severe hypothermia. So they will ask you a lot of questions related to hypothermia. And very important for preterm babies, what will you do now? The kangaroo mother care, KMC, we have to provide. Okay, what is the most important keyword we will tell in kangaroo mother care, student?
So skin to skin contact.
To skin contact. As long as you say skin to skin contact, you will be left. Okay, so skin to skin contact for kangaroo mother care. And what is this CRT?
So capillary refill time. So it must be usually less than 3 seconds.
Less than 3 seconds. So you press over the sternum for 5 seconds and leave and see whether the blanched part becomes perfused again. Okay, so it should be less than 3 seconds. If it is prolonged, the perfusion is poor, the baby is going in for shock. Okay, so these are the importance of vitals. So they will ask you the normal vitals. Jaundice, they might ask you further, where will you look for the jaundice, what is severe jaundice and all those things. Acrocyanosis, they might ask you 1 point or 2. Edema, sometimes they might ask you, where will you look for edema, they might ask you. Okay, so since the babies are not mobile, they don't walk, they will have dependent edema. Where will you look for dependent edema? There. In the bottom, no, in the sacral region. Okay. Anthropometry.
Anthropometric measurements. Birth weight is 3.1 kg. Today's weight on examination is 2.9 kg. The length is about 60 centimeters. Head circumference is about 34.5 centimeters. The chest circumference is about 33 centimeters.
Okay. So anthropometry is a very important component. So here they will ask you a lot of important questions. So they will ask you what is low birth weight, very low birth weight, extremely low birth weight. Shirin, can you answer what is low birth weight?
Low birth weight is when the baby's birth weight is about less than 2.5 kg, irrespective of the gestational age, is called as low birth weight.
Very good, very good. Irrespective of the gestational age. So any time, any point, any baby, preterm or term, if it is less than 2.5, it is low birth weight. Okay, very low birth weight.
The birth weight is less than 1.5 kgs, irrespective
Very
of
low
any.
birth weight. And if it is less than 1 kg, it is extremely low birth weight. Okay, and you have to plot in intergrowth 21 chart. There is a separate chart, intergrowth 21 chart. This weight against the gestational age. Then you will get the small for gestational age, appropriate for gestational age, and large for gestation. So they will ask you definition for that also. Shirin, what is small for gestational age?
So if the on the graph, if the segments fall within the less than 10 centile, we term it as small for gestation age.
More than 90th centile is large for
Large for
gestational
gestation
age. So there are specific problems for both the conditions. So simple term is for a 34 weeker, 1.8 kg is always low birth weight. Okay, 1.8 kg irrespective of gestational age is low birth weight. Okay, but 2.8 kg for a term baby is small for gestational age, and 1.8 kg is appropriate for gestational age for a 34 weeker. Do you agree, Shivam?
Yes, sir.
Okay, so the same 1.8 kg is appropriate for gestational age for a 34 weeker. It is small for gestational age for a term baby. Okay, so that we need to understand. So you need to understand what is SGA, AGA, LGA, and what is the definition for that. Okay, and can you say about the weight gain pattern? How does the baby lose weight, gain weight after birth?
Initially,
They will ask you these questions. That's why I'm stressing.
so in case of the birth weight actually reduces about weight, there's weight loss in the first 7 to 10 days, about 8 to 10%.
Okay, good. And then
After
they
that,
regain. So they regain their birth weight by around 10 days. So maximum permissible is around 10%. For preterm, they up to 15%, and they may take even up to 2 weeks to gain their birth weight. So that is the weight gain pattern. After that, how do they gain weight? Every day around?
the first 3 months, 30 grams per day. For the next 3 months, 20 grams per day. For the next 3 months, 15 grams per day. And for the last 3 months, it is 12 grams per day. So,
Okay,
and
very
after
good.
1
So
year,
even if you say they gain after gaining their birth weight, the baby starts gaining 30 grams per day, it is good enough. So that is a very good weight gain pattern. And with regards to head circumference and chest circumference, at birth, the head circumference will be more than the chest circumference. When does it cross, or when does it become equal? Head circumference, chest circumference?
so during 9 to 12 months.
Okay, so around 9 to 12 months. Then here, once head circumference comes, they will ask you the definition of what is microcephaly, what is macrocephaly. Okay, so how many standard deviation is microcephaly, Shivam? Less than
Standard
3
deviation.
standard. So microcephaly is less than 3 standard deviation, and macrocephaly is more than 2 standard deviation. Then they might ask you about ponderal index. So ponderal index, it is sometimes they might ask you, so weight in grams divided by length in centimeter cube. If it is less than 2, it is asymmetrical IUCR. If it is more than 2, either it is normal or it is symmetrical IUCR. Okay. You agree, Shirin, this part?
Yes, sir. Yes, sir.
Okay. So anthropometry is one place where they might ask you more questions. Then head to foot.
Head to toe examination. Scalp hair present normally. There's mild overriding. The head anterior fontanelle is felt, open, rhomboid shape, 2 by 2 centimeters and soft. The posterior fontanelle is open, 1 cross 0.5 centimeters and soft, is felt. There is symmetric facies. There is no signs of birth trauma or any cephalohematoma or caput medicine. Caput and succedaneum. The eyes are equal in size. Normal light reaction. There is no cataract. Red reflex is present. There is no redness, watering, or discharge or subconjunctival hemorrhage. Ears normal in size, shape, and position. Elastic recoil is present. instantaneously, and there's no abnormal sinuses, tags, or hair in the pinna.
Okay, good. So newborn, remember in examination, there is no respiratory system, abdominal examination, CNS examination, which you have to concentrate. So it is the most important examination part, Naka. It is the head to toe examination. RS CVS, they will accept if you just say S1, S2 heard, and RS bilateral RN3 present, no added sounds. So they will accept that. So what is more specific for a newborn is the head to toe examination. And what you are basically looking for is from head to foot to rule out any congenital abnormalities. So the most important job for us is to rule out any congenital abnormalities. It could be major congenital abnormalities. If the baby is born at the delivery table, you look for major congenital abnormalities. So look for the anal atresia, look for whether there is any imperforate anus, look for any frothing per mouth, any esophageal atresia is there. So that will be the major at the time of receiving the baby. Okay, but when the baby has been given you for exams, mostly there will be minor congenital abnormalities. So you have to pick that up. It could be a small tag pinna, okay, pre-auricular tag. Okay, you have to tell that. There could be a supernumerary digit, an extra small digit in the hand. You have to tell that. Okay, whether there is any extra digit, or it could be like there will be a small cleft palate could be there. So the minor congenital abnormalities, if it is there, you have to identify and tell. Okay, and head, from head to foot, you start looking for, in addition to congenital abnormalities, are there any dysmorphic features? Okay, are there any dysmorphic features like for Down syndrome? Most important will be Down syndrome. So look for low set ears, any mongoloid slant is there, or any simian is there. So what is expected of you from head to toe examination is congenital abnormalities, any dysmorphic features, okay, and go from up top to bottom one by one. And for each part in the newborn, they will ask you specific questions. Okay, for example, in the head, they will concentrate about your fontanelles. Okay, so anterior fontanelle, posterior fontanelle. Okay, so when does this close, Shidan? Posterior fontanelle?
So the posterior fontanelle usually closes at birth, sir, but it may present in 3% of people, babies, sir.
But it closes early. It closes within another 2 weeks or 4 weeks. It closes. It's the post anterior fontanelle which stays for a longer period. Okay. So, and okay. And next is what anterior fontanelle. How do you look for the fullness of the anterior fontanelle? Will you palpate it in the lying down position, or you make the baby sit and palpate?
So the baby sits on the mother's lap.
Okay, slightly in a lifted position, you will be palpating the anterior fontanelle. Okay. And what is this red reflex implies? Eyes red reflex.
So we must check whether there is a red reflex of the fundus. If you're not seeing a white reflex, there can be any congenital cataract or any retinoblastoma, any tumors.
Okay, so you shine your torch and it should be a red reflex. If it is not there, if you have a white reflex, probably we are dealing with some cataract or something else. Okay, then next. Okay.
The lips and mouth appear normal with no cleft lip or palate. Nose, septum, ala, bridge, philtrum appears normal with no nasal flare. Neck, normal neck movements with no swelling or other abnormalities. Chest, nipple bud is more than 5 millimeters. Areola is well formed. There is no widening of nipple, accessory nipple, and no intercostal retraction is present. The umbilical sump appears healthy. There is no periumbilical erythema, discharge, or meconium stain. The external genitalia, the penis is 2.5 centimeters in length. Scrotum is well formed with rugosity and pigmentations, and both the testes are present within the scrotum, sir.
Okay, so good. So we are looking for some minor congenital abnormality. is there any cleft lip or cleft palate? Okay, and how is the umbilical stump? Most important will be how is the umbilical stump? Very specific for the newborns. Is there any discharge? Is there any periumbilical erythema? Okay, so something umbilical stump will be looking for. Okay? Then most important, since you are doing head to foot examination, this is the right time to talk about the gestational age. Ballard's chart we usually apply for the gestational age to differentiate whether the baby is a preterm or a term. It's compromised of both physical and neurological features. Okay. Can you tell something about Shridhar Ballard's chart? How will you say whether this baby is a preterm or a term?
So based on the neuromuscular maturity scoring, based on the posture,
Okay,
the
good.
the arm recoil, the popliteal angle, using the star sign and heel to ear measurements, and we score it from -1 to 5, sir. From that.
Okay, good. So based on that, we have a scoring. Similarly, the physical maturity features are there. What are the physical maturity features for to see whether it is preterm or term?
Sir, we must see. Sir, not sure, sir.
So you look for the ear recoil. Okay, I have a video of that. I will show you. So you look for the ear recoil. You look how is the nipple formed, how are the sole creases, and how is the genitalia. So here you have said that the rugae is formed well, pigmentations are good. Suggests that the baby is term baby. But if it's a preterm, the rugosities may be less, the pigmentation will be less. Okay. So from head to foot, you look for major malformations, minor malformations. Okay, you look for any dysmorphic features are there or not. Okay? You look for any dysmorphic features. Similarly, you try to put a gestational age assessment, whether the baby is preterm or term. You look for the physical features and neurological features. I will show the video. It runs for 5 minutes. It's a very good video. Plus, in addition to that, there are some normal findings in the newborns which you have to mention. Okay, have you heard of this Shivan? Erythema toxicum, milia, acne, Mongolian spots?
Yes, sir. Amelia, which is a normal sebaceous retention cyst. In case of erythema toxicum,
What is this, Shivan? What is this?
so this is erythema toxicum, sir.
Okay, erythema toxicum. So there is a surrounding erythema with vesicles in between. So this is a normal finding. Okay, erythema toxicum neonatorum. So not only congenital abnormalities, some normal findings will also be there, which you have to mention from the head to foot examination. So this erythema toxicum neonatorum, very good. This one, the left side, Shidan. This is a transient pustular melanosis. Okay, transient pustular melanosis. So the hyperpigmented patches. No, this is very transient. So transient pustular melanosis. How about this, student? The right side. This is a stork bite or salmon patch. Okay, salmon patch is very common. Babies will have capillary malformations. By 1 year, it disappears. So these are all you have to mention it on seeing, and you have to mention. Can you identify the student? Will be able to do it.
Spots, sir.
Mongolian spots. No?
Mongolian spot.
Okay. So Mongolian spots are the grayish patches usually seen on the back and in Asian ranges. It may look like a nevus, but it's not dark as a nevus, and it slowly will disappear over 1 year of age. Okay. The left side, Shidan, this one.
Sir, that is Milia, sir.
This is milia. The small whitish spots. No, so this is milia, and the right one.
Cutis marmorata, sir.
Okay, cutis marmorata. So some mottling like features. If the baby is sick, we say that the perfusion is not good. But in a healthy baby, you can get some mottling like this. So this is cutis marmorata. Okay. Even you can continue with the part.
The anal opening is patent and present. The skin is pink. There's no birthmark, no jaundice, no neurocutaneous markers. Hips, Ortolani and Ballard test is negative. The limbs, normal movement of all 4 limbs. Creases are present and deep over the entire palms and soles.
Okay, so almost you have elaborated the features suggestive of term and preterm in the book itself. That only is Ballard's chart. Okay, so here creases are present deep over the entire palms and so that is a suggestive of the baby is a term baby. Good. And you have also checked for ortholany and Barlow's test, which is to screen for what, Shirin?
So the developmental dysplasias of the hips.
Congenital hip dislocation. So you screen for the congenital hip dislocation. So you have to mention all this in the head to foot exam. Okay, good. So just take another 5 minutes about the Ballard's chart. If you are able to, if you are not able to hear the voice, you just tell Shirin. I will give the voice.
The Ballard exam is a scoring system that can determine the gestational age of newborns to within 1 to 2 weeks. The exam is most accurate within the first 12 to 20 hours of life. There are 2 parts to the Ballard exam, the neuromuscular component and the physical component. The examiner gives a score ranging from -1 to 5 for each part of the exam based on the Ballard criteria. Some people choose to do only the physical exam components and double that. However, a more accurate assessment of gestational age is obtained by scoring both components. To assess the physical components, begin by looking at the eyes and the ears. Determine if the eyelids are fused. Eyelids should be unfused by 28 weeks gestational age. Assess the recoil of the ear by folding down the exterior ear. The ear becomes more formed with faster recoil with increased gestational age. This baby has formed and firm pinna with instant recoil, consistent with a score of 3. Next, assess the skin. The best way to do this is by examining the abdomen. As babies get older, the skin is less translucent, fewer veins are visible, and there is increased drying and cracking of the skin. This baby has a rash and just a few visible veins, both consistent with a score of 2. Next, assess the diameter of the breast bud and the definition of the areola. As the baby ages, the breast bud grows in size and the areola becomes more defined. This baby has a 1 to 2 millimeter breast bud and a stippled areola, both consistent with a score of 2. Next, assess the lanugo. Lanugo is the fine hair on babies and is best assessed on the back. Lanugo first develops at 20 weeks, progresses to cover the entire back, and then recedes. This baby is mostly bald, which is equal to a score of 4. Next, examine the plantar surface of the foot. Measure the length of the foot. The length of the foot in the term infant should be greater than 50 millimeters. This baby's foot is 78 millimeters. Next, look at the distribution of deep creases on the plantar surface of the foot. Creases develop first on the toes and progress to the heels. This baby has creases over the entire sole, which is equal to a score of 4. The final part of the physical component is the assessment of genitalia. Evaluate the male genitalia by focusing on the degree of rugae in the scrotum and the location of the testicles. As the baby matures, there will be increased rugae and the testicles will descend deeper into the scrotum. This baby has many rugae and the testes are down, consistent with a score of 3. Evaluate the female genitalia by focusing on the size of the labia minora and labia majora. Labia minora is larger earlier in gestation. By term, the majora covers the labia minora and the clitoris. Now we will begin assessing the neuromuscular component. Begin by assessing the posture. Observe the baby on his back when quiet. Pay particular attention to the flexion of the extremities. Flexion increases with gestational age, and arms increase in flexion before legs. This baby's posture consists of nearly full flexion of the arms and slight flexion of the legs, consistent with a score of 3. To assess the square window, flex the wrist and measure the angle between the thumb and the forearm. This angle decreases with increased gestational age. The angle in this baby is about 45 degrees. consistent with a score of 2. Next, assess the arm recoil. To do this, flex the elbow for 5 seconds. After flexion, fully extend the elbow and release. Measure the angle of flexion after releasing. This angle decreases with increasing gestational age. This baby has an angle of less than 90 degrees, consistent with a score of 4. Next, assess the scarf sign. Pull the hand across the chest as if the arm is a scarf you are placing around the baby's neck. Determine the position of the elbow in relation to midline. As the gestational age increases, the elbow is less able to pass the midline. This baby's arm nearly crosses the midline, consistent with a score of 3. Next, assess the popliteal angle. Flex the hips and hold the leg so that the thigh rests on the abdomen and the buttocks are still in contact with the bed. Apply pressure gently to the ankle to extend the knee and measure the popliteal angle. The angle decreases with increased gestational age. This baby's popliteal angle is about 90 degrees, consistent with a score of 4. The heel to ear maneuver is similar to the popliteal angle, except that the examiner holds only the foot and the thigh may be alongside the abdomen or in the knee-chest position. The hips still maintain contact with the bed. Assess the distance from the foot to the head and measure the angle from the foot to the bed as soon as possible after you push the feet towards the head. The longer you maintain this position, the more stretching will occur to alter the results. The angle decreases with increased gestational age. This baby's foot is far from his head with an angle of about 90 degrees, consistent with a score of 3. After you have completed both the physical component and the neuromuscular component, add up all the points assigned. In this case, the maturity rating is 37, which corresponds to a gestational age of 39 weeks. This baby's estimated gestational age by both last menstrual period and ultrasound is 40 weeks.
So that's the Ballard chart. So neuromuscular, you remember, as the baby becomes more and more term, the tone will be very high, tone will be good. So the angles all will be acute in angles. And physical maturity, the nipples bud will be well formed and the ear recoil will be very good. Sole creases will be fully present. So that's how you differentiate the term and preterm. Okay. Coming to the system.
CVS, S1, S2 heard, there is no murmur, no thrill, no parasternal heave. RS, normal vesicular breath sounds are heard with no added sounds or no signs of respiratory distress. Abdomen, soft protruding abdomen, there is no visible peristalsis or pulsation with no scars or sinuses or dilated veins. The CNS, the baby is alert, quiet with a normal cry. Motor, there's normal range of movements present with no resistant to passive movement.
Okay, so almost as I said, systemic examination is they don't expect much because most often it is going to be normal. Okay, and maybe in abdomen you may palpate 1 or 2 centimeter of liver below the costal margin, which is considered normal. And what is more important in CNS is make sure the baby is having good muscular tone. As I said, the universal flexure is a good muscular tone, and make sure that all the 4 limbs are moving equally. Sometimes in during a difficult delivery, they might have clavicular fracture, etc. So and Erb's palsy, where there will be paucity of movement of the limbs on one side. Okay, and reflexes. So you can examine the cranial nerves in babies also, that Shiden will be elaborating. Most important will be the primitive reflexes, which you have to elaborate. Okay. Okay, continue, Shiden.
Cranial nerves, optic nerve, there is blinking of eye to bright light. Oculomotor trochlear abducer nerve, that is doll's eye reflex is normal with conjugate eye movement in opposite direction on turning the head. Trigeminal nerve, the rooting reflex is present. Facial nerve, there is no gross facial asymmetry or no deviation of mouth during cry. The vestibulocochlear nerve, startle response is present. Glossopharyngeal and vagus nerve, there is no history of nasal regurgitation of feet or drooling of saliva with gag reflex present. Spinal accessory nerve is normal, neck movements is seen. Hypoglossal nerve, there is no wasting, fasciculation, or any deviation of the tongue. So,
Okay. So good, Shirin. Sometimes the question will be how to examine the cranial nerves. You should not say that, sir, the baby is a newborn, the baby is not cooperating. We cannot examine the cranial nerves as in the adult. Okay. So there are some shortcuts which Shidan has used to examine everything. Okay. So for example, the menace reflex. Okay. You bring your hands or a bright light before the eyes are going to blink, which means that the optic nerve is good. Similarly, doll's eye movement. You turn the head to one side, there is a movement of the eyes to the opposite direction. So, which means that the third, fourth, sixth cranial nerves are intact along with the brainstem. Okay, and you are rooting reflex. The sensory part will be your trigeminal. So rooting reflex is one way of saying the trigeminal nerve is intact. Similarly, facial nerve, you see when the baby is crying if there is any deviation of the mouth. And most important is the startle reflex. You do a clap and see whether the baby suddenly startles. With the arms will be abducted. Okay, suddenly the baby will startle. So to a loud sound. So which means that the baby is hearing well. Okay. Similarly, examine the sucking and swallowing reflex for the 9th and 10th and see whether there is any regurgitation of the feet or not. So you can examine the cranial nerves. You can do a CNS examination just like in the adults, but there are certain shortcuts which you should understand. Okay. Okay. Reflexes.
reflexes. The Morose reflex is positive with symmetrical bilateral rapid complete abduction and extension of the upper limb and opening of hands, followed by slow adduction and flexion with extension of the head on sudden drop of the flexed head through 30 degrees, followed by a cry. Rooting and suckling reflex are positive on simulating the angle of the mouth of the lips. Babinski sign is positive with dorsiflexion of the great toe with extension and fanning out of the other toes. Grasp reflex is positive when an object is touched on the radial border of the palm between the index finger and the thumb, the baby grasp. Tonic neck reflexes is positive with extension of arm and leg on ipsilateral side with flexion of the limbs on the contralateral, just one side.
Some voice issues are there. Kindly pardon me, I'm not able to correct it. In the comment section, they have asked for the. You are able to hear, Shidan?
Yes, sir.
Okay. So, most important part in newborn will be your reflexes. So, they will be asking about questions about when does the morose appear, or when does the reflex appears, when does it disappear, how are you going to elicit. There might be certain special scenarios about the reflex. Similarly, reflexes, if you remember the morose reflex and rooting and sucking reflex, morose, rooting and suckling reflex, those are the two important reflexes they will ask you. Grasp reflex and asymmetric tonic reflex, that is the two next reflexes they will ask you. But they expect you to tell at least the rooting, sucking reflex and morose reflex. So, Shiran, so when does the morose reflex appear actually?
Sir, it appears by 28 to 30 to 38, 32 weeks of gestation, sir.
Okay, it starts appearing early, but fully mature morose reflex, it will be present in a term baby. But it can be present, as he said, even in preterm babies, they have some amount of morose reflex will be present. And when does it disappear, Srinan?
Sir, it disappears around 2 to 3 months of life, sir.
Okay, so around 3 months around it will disappear. And how are you going to elicit?
Uh, so, so we just hold the baby using the head over our in a semi-extended position, and we just try let down the baby incline the baby a little bit, and we catch the baby's falling head, sir.
Okay. So suddenly extend the baby from the flexion. So hold the baby with the neck flexed and suddenly extend the baby neck. So the response will be, so what is the response? It is abduction. Student, abduction.
So during the first,
The response will be abduction, extension, hands will open, followed by flexion, adduction, and closing of the hand, as if to embrace the mother. So that's how the Moros. So if you in the last picture on right side, it is the Moros. Okay. So special scenario. So what is asymmetric Moros?
sir, in case of brachial plexus injury or in case of any clavicular or humerus injury, what happens is there is one side would be the baby would be adducting, whether the other side would be paralyzed.
Okay, so that is asymmetric Moros. So when will Moros reflex depressed? When will it be depressed?
So in case of brachial plexus injury,
Depressed means suppose the baby is birth asphyxia. So the Moros will be depressed. So you will not have a very good Moro reflex there. So this is some special scenarios where Moros you can. What is asymmetric Moros? Will ask you. When is the Moros reflex? That is depressed Moros reflex. Okay, it will not be a very good Moro. So suppose the baby is birth asphyxia, due to the Moro, it will not be so good. Okay? Similarly, rooting reflex, sucking reflex, when does it appear and disappear? Shouldn't?
sir, 1 second, sir.
So, rooting and sucking reflex, actually they will be present, as you said, in preterm babies will also have the rooting and sucking reflex. So, around 32 weeks, the rooting and sucking will be there. And when does it disappear? Around 2 months of age, it starts disappearing. Okay. So, how to elicit? We'll ask. So, keep your finger along the angle of the mouth. The baby will try to turn towards your finger as if to search for the mother's breast. So that is the rooting reflex. And sucking reflex, ideally, it's better to examine how the baby is feeding the mother. So that is the way of doing the sucking reflex. Better not to insert your fingers and introduce some infection. So how do you do the sucking reflex? Ideally, it should be observed how the baby breastfeeds. So that is the sucking reflex. Babinski reflex, everyone knows. Usually, you will have fanning and upward movement of the toes. So, Babinski reflex will be present. Do not use any sharp objects for doing the Babinski reflex. And grasp reflex, the reflex is like whenever you keep your finger in the hands or the legs. So, okay. So, the baby tries to grasp the object. So, any object you keep in the palm as well as the sole. Okay, sole, anterior part of the sole, when you place it tries to grasp and it disappears. Grasp reflex, the palmar grasp has to disappear by 2 months, then only the voluntary grasp will come, and the plantar grasp disappears around the 6 months. Okay, tonic neck reflex, the picture you can see, it will be very nice. So the first one is the rooting reflex. Right side, you are looking at the sucking reflex. Okay, and below is the palmar grasp. Okay, and here you are seeing the Babinski's test. Okay, and below is the asymmetric tonic reflex. Asymmetric tonic is nothing but the baby turns to one side. What is happening to the limbs? The upper limb, it starts extension. Okay, in the side of the baby turns. The other side, it is flexion. And Moros, it's a very good Moros response. The arms starts abducting followed by the adduction. So you need to know when it appears, when it disappears, some special scenarios. Okay, like what is asymmetric Moro, etc. Okay. Okay, Shidan.
A term, 5 days old term born baby
Finally, we
boy.
have come to the summary part. Okay.
Yes, sir. A 5 days old term born baby boy, appropriate for gestation age, born out of normal vaginal delivery, with birth weight of 3.1 kgs, is apparently healthy and well baby, with no feeding difficulties, no jaundice, no distress, or any other congenital anomaly is given adequate care in the postnatal ward of Tago Specialty Hospital.
Okay. So here we are going to give the summary of the history as well as the examination findings. So demographic details. You start with the demographic details, followed by the any pairs, no significant antenatal or perinatal complications. Okay. And the baby cried immediately after birth. What was the birth weight? And the baby was not admitted. And baby had any problems, you have to mention the problems, whether jaundice was there or anything. And the baby is kept for only 4. And examination findings you are going to say later on. So all the positive findings, both the history as well as the examination findings, you put it in the summary. And finally, diagnosis. How do you say the diagnosis? Shirin?
Sir, the baby is 5 days old, term born baby boy, appropriate for gestational age, with no feeding difficulties, no jaundice, no distress.
Normal
and, the baby is normal and well baby.
Normal newborn. So diagnosis will be a very short. So full term, appropriate for gestational age, of birth weight 3.1 kg, 5-day-old, normal newborn. Okay, normal healthy newborn. Okay, so that will be your final diagnosis. If you have any problems, then neonatal jaundice. So what's your diagnosis? Full term AGA, birth weight, day 5 with neonatal jaundice. So that will be your final diagnosis. So summary will be all the positive findings, you put it in the summary. Summary of the history alone, you do the summary of all the positive findings, and finally you give the diagnosis. Okay. So any doubts with examination? Shirin, you have any doubts? And others can put it in the chat section. Any doubts, you can put it in the chat section. Or,
so should we talk about the feeding difficulties, as in I've given the summary part, like there's no feeding difficulties, jaundice or distress. So should we be emphasizing much on this, or we can leave it, sir?
Breastfeeding, exclusively breastfeeding, you can say. With no feeding difficulties. I think you can mention the feeding difficulties because it's a very important component, for a newborn. So in the summary, you can give 1 or 2 negative findings also, you can see, because if you feel feeding difficulties is very important, you can add that. But not all negative findings, you need not add it. Summary is mostly the positive findings. You can just say child is exclusively breastfeeding and without any difficulties.
Okay, sir.
I think it's good. And plus one few more important questions you have to read is one is IMNCI. So IMNCI related to newborn, better be prepared. So they will ask you, so what are the danger signs? Okay, what do you mean by when will you refer the baby? So all these things. So important questions means the resuscitation they will ask you. So remember to read and go the neonatal resuscitation. Similarly, IMNCI protocol for taking care of the baby, they will ask you. So when what do you understand by the pink referral? When will you refer a newborn baby or a baby less than 2 months? So what are the criteria? So those things they will ask you. Okay. Similarly, breastfeeding issues, they will ask you. So what is attachment? What is proper positioning? And what is breastfeeding jaundice? What is breast milk jaundice? So related to jaundice, they will ask you a lot of questions. Okay, how will you treat? What is phototherapy? So basically, a lot of questions from newborn. At any point of time, it will branch out. So as you keep presenting, at any point of time, they will stop you and they will branch you the question. So you have to keep prepared for that. Okay, I think it's fine. We can wrap up. If any doubts, please post it in the chat section. Raghu?
Yes, sir. I guess there is no doubt. So we can just wind up the session, sir. If any doubt, they can just post it in the comment section so that later we can just clear them.
And I would like to all join our Telegram group. As Raghu said, it's Pete's Medu Champ. It's a Pete's Medu Champ. We are daily posting MCQs in the group. So it will be helpful for you to solve the NEET and next preparation questions. So every day we are posting around on a specific topic, 5 MCQs. So it's at Pete's Medu Champ. Please do search in Telegram and join our Telegram group. And thanks, Shidan. It was a wonderful presentation.
Thank you so much, sir.
It was very proper. You are third year, no?
No, sir. Final year, sir.
Final year. It's good actually. So right from the start, and you even answered all the questions, sir. So you all the best for your exams.
Thank you so much, sir.
Thank you, sir. Thank you so much, sir.
Thank you.